Welcome to the Menopause and Cancer podcast, where we speak with cancer patients, survivors, and incredible experts in their fields to help us find solutions to our symptoms and ideas to improve our health. I'm your host, Dani, and today I'm joined by someone whose voice and expertise has been instrumental in shaping one of the most important resources I have ever worked on. My new book, Navigating Menopause After Cancer. It was out last week, and I'm so grateful for all of your lovely and kind messages already. Today, I am joined by Mr Vikram Talaulikar. He's a consultant in reproductive medicine and honorary associate professor at University College London. He works as menopause specialist at UCLH. He runs his private practice, Menopause Clinic London, and he also sees patients through our fully funded menopause clinic at Menopause and Cancer. And if you've had any of our previous episodes with him, you'll know how generous he is with both his time and also insights. Now, confession time. His copy of the book actually hasn't arrived yet, but the contribution he has made, in particular, the groundbreaking table on the safety of HRT after all different types of cancer, has already really been quite transformational. I have woken up and I've received messages from clinical nurse specialists, from other healthcare professionals, from oncologists to say, oh my God, to have all of this in one table is pretty amazing. I've also had messages from patients who've gone through the table, found their type of cancer, especially if it's been a more rare type of cancer, and really been very intrigued to see what they find. That just shows the value of his work, and I can't thank him for this groundbreaking contribution to our book, Navigating Menopause After Cancer. And today we're revisiting the topic we know matters deeply to our community, HRT after cancer. We've talked about it before, especially about HRT after breast cancer and gynae cancers, but this time we need to broaden the lens. What do survivors really need to know? How can we finally start making this information clear, safe, and accessible? And I also want to ask Mr Talaulikar, what do you do with the information from our book? And in particular, if perhaps you've been given different advice so far in your care. I know it's very difficult to manage as a patient when we've been given conflicting advice sometimes. So I'm going to ask him all of those questions. This is a really important conversation for all cancer survivors, regardless of the type of your cancer, and all healthcare professionals looking after cancer patients. Mr Talaulikar, welcome back to the Menopause and Cancer podcast. How are you today?
Thank you, Dani. Always a pleasure to do the podcast. I'm good, slightly hotter than I would like, but still okay. And hope you're good.
Very, very well. You know, the first time you came onto the show was right at the beginning, more than 2 years ago now, where we talked about the evidence of and the benefits and negatives of HRT after breast cancer. But a lot has changed in those 2 years for you in your practice, for us at work. And I feel there has been many positives. More people talk about menopause after cancer now, but we still meet hundreds and hundreds of people every week and every month that feel like they've not had the help they needed. What's it been like for you in your clinical practice, in your private practice? What have you observed?
So I think you summed it up well, Dani. There has been certainly much more positive work now. If you compare what is happening in the field of menopause following cancer now as compared to 5 years ago or 10 years ago, you can see lots more conversation happening. You can see that people are recognizing the quality of life issues, the symptom management of menopause-related symptoms after cancer. Health professionals are willing to train themselves, talking more about it. People, cancer survivors, they are talking about it. Campaigners like you, charities like Menopause and Cancer, they're working so hard so that patient voices can be heard. Researchers are getting more interested in this field. You can see more papers coming out now in this field than ever before. So I think there has been a lot of positive work. Even when I'm sitting in the clinic, I have patients who are probably a little bit better informed as compared to when I was sitting in the clinic and seeing patients 10 years ago. But somewhere there still remains a lot of gap or a lot of voids which we will have to overcome to make this experience available to everyone. So,
Mm.
yes, there are more women getting help, more women talking about it, more health professionals offering support. But you still come across patients who have not been given help. So they've struggled to
Mm.
get help from their oncology team, their primary care team, other associate health professionals who may be involved in their care. There hasn't been talk about menopause before or after treatment. There hasn't been support offered or treatment options offered. So there remains a big void for many individuals, not everybody, which still needs addressing. And that's the challenge for us for the next few years to come.
Yeah. And of course, with the general trend across the entire world of the safe prescribing and understanding that hormone replacement therapy in many cases outweigh the risks. Of course, we need to bring that HRT hormone replacement conversation into the cancer survivors conversation, because we talk about it anyway. Either people feel a little bit annoyed that all of their friends seem to be on HRT and they can't have it, or people are frustrated that no one gives them the advice whether HRT is applicable to them, or the ones where HRT is not contraindicated, it takes them a long time to access it. Why is there still so much confusion around HRT after cancer?
I think it's the lack of education primarily. That's the problem here, is that not all health professionals may be up to date with what is HRT, what do modern hormones do, how effective are they, how safe are they, following cancer, what are we looking for in terms of symptom management, which are the few cancers where HRT is contraindicated. So we know, for example, that HRT now consists of modern hormones, which are mostly body identical, which are often delivered through the skin rather than oral route. And all that makes them much more safer than what was HRT 10 years ago or 20 years ago. We also know that over the years, we've been accumulating small pieces of data and studies where we know after most cancers today, HRT does not seem to be a problem, doesn't increase recurrence of cancer, but rather addresses quality of life issues, and in fact helps prevent complications, mortality from heart disease, bone loss, and a few other problems. So, for those women who don't have those small number or types of cancer where HRT could be a problem, for majority, it's completely safe to offer it as an option for treating menopause. And even for those where there is that small problem where the receptors may be sensitive to hormones, there are certain situations where you could still offer it on an individualized basis, depending on what the patient perceives her benefits and risks are, what the clinician perceives benefits, risks are, and the two can meet in the middle.
Mm.
This is biology. This is not always 2 plus 2 equals 4. And so,
Mm.
really, it is a kind of a shared decision making or a shared sort of consultation between the patient, what her expectations and needs are, what is she suffering from, versus what are the real benefits and risks, and then taking on those board. So in a way, HRT conversation is really critical when it comes to menopause after
Yeah.
cancer. Majority will be able to have it if they wish to do it. It's not a must for everybody, but for one who wants to take it and consider it, that individual must get access to it and know the facts, the benefits, and the risk.
Mm. Mm. What do you hear from patients now? So we're well into this menopause revolution, and maybe in general, the menopause revolution has already peaked. Now Australia is catching on, and America was catching on last year, right? And maybe in the UK, it's already peaked with campaigners and celebrity doctors and other celebrities. What do you hear from patients about HRT when they come into clinic? Are they curious, or are they demanding now? Do they say, I want to have HRT? Or what has that narrative changed from patients a little bit?
I think it's very individual. I would say not many patients are demanding at all. I think patients are curious. That would be a good word to use. Most patients now want to know, how is my menopause going to play out, first of all? How the symptoms will be. Will they be really distressing, or will I be having symptoms which are not as bad? What will be the impact that I've gone through menopause now in the next 10, 20, 30, 40 years of my life, whether it's my cognition, my heart, my bones, my physical energy, and my genitourinary health? They want to know that first of all, and then say, What are my options? How can I make sure I live well for the next 20, 30, 40 years? Is it HRT? Is it non-HRT? Is it lifestyle? And if it is HRT, for my specific type of cancer, stage of cancer, the operation or the chemo I have had, what is my chance of this cancer coming back or another cancer happening? Because I've already had it once, I want to be sure I'm not taking undue risk. That is
Mm,
exactly the conversation most women will come and want to have when they are
mm,
considering treating their menopause symptoms.
mm. And of course, when you hear in detail all of those questions, so many detailed questions, it is a question for a specialist and probably also for a multidisciplinary team to answer for that patient, right? And
Correct.
so I think the expectation that we might find these answers in general practice, that's unrealistic. And even within our oncology teams who are not menopause trained, or our breast cancer nurses, for example, who are not menopause trained, it's almost impossible to find those answers there, which is why specialist advice is so important. At your Friday clinic, I believe you run a Friday clinic at UCLH. Tell me, how do you just see cancer patients there? Is that the dream? Are we going after this, all of us?
So the Friday clinics are very interesting because in a way we started with just general menopause, but over the years the Friday clinics have got so many women who've had menopause as a result of some or other form of cancer that we're really now in a position where we see women coming with history of various different types of cancers, whether it's rare cancers, common cancers, head to toe, have been treated with surgery, chemo, radiotherapy, immunotherapy. So many new treatment drugs are available, some of which even I'm not able to keep pace with. And so you can see that as the field is expanding, more and more women are doing well with cancer treatments. They're asking questions about their fertility, they're asking questions about menopause, how best can they manage hormones from this point on for their life. So the clinic is bustling with patients, full of questions. And as you rightly said, primary care physicians may not be the right people to do decision making here, because even for us as specialists we need input from many people sometimes to come to the right decision for that particular patient, whether I'm talking to a breast oncologist, whether I'm talking to a hematologist who looks after leukemia lymphoma patients, or I'm talking to a gynecological oncology patient for cervix cancer or endometrial cancer. It makes sense to join hands, because my knowledge about hormones or HRT will be one issue, but the knowledge about how that person has done on their cancer treatment, what is the particular stage and what's the likelihood of cancer coming back if they don't do or do certain treatments, the oncologist is the best person to advise. So while we are far apart, it's a disjointed care. But if I can have somebody who I can ask quickly, what is your opinion? My opinion is this. Can we join forces and explain the patient what is likely to be happening from this point on? We're not there yet with the Friday clinics, but that's where we are heading. If we can get
Mm,
such a big joint service where I have the specialist oncologist linked with us alongside the patient, and they get opinions of both physicians in one go to plan the next
mm,
5 year care, that's a dream come true. Hopefully we will
mm.
get there in most big hospitals as time progresses.
Mm, absolutely. And I see this popping up in lots of different places as I speak to more and more clinicians. And it's usually driven by amazing doctors like yourselves who recognize this need and who try and get the funding and who try and put all of their time and resources into servicing a few patients a week or throughout their month. And I think it's always the individual at a specific hospital trust or a hospital that is creating that change at the moment.
Yes.
And that's incredible. It is exactly this knowledge that you facilitate in your Friday clinic amongst your other colleagues that we wanted to sum up in the table of the book, didn't we?
Yes.
And
Yes.
I can't thank you enough for your encouragement, because I remember you saying, Dani, I think you've just got to do and write this book now. Come on, just just do it. And I had given up so many times, but it was really that encouragement that kept me going when I thought, I can't do this. I've not got it in me. I don't know when to do all of this. You've come up with a table for us that I have not seen anywhere else. I haven't seen it in any other resource. And it is a table that lists every single type of cancer with their subtypes and whether hormone replacement therapy is systemic or vaginal estrogen, so local hormones, local estrogen, is possible. How did that table come together? How did you pool all of this information together? To me, it's quite a groundbreaking table. How did you feel working on it, and how did you pull all of that information together?
Well, I feel a little bit what I should say, embarrassed to say that it's all that we've come up with this all de novo. I think this is a credit for so many researchers and paper writers and sort of
Yeah,
oncologists and hormone specialists out there who
yeah,
individually, in their papers, in their studies, in their books, in their whatever drafts they have done over the years, they have published about various cancers, their experience, what the recurrence has been, whether you've used HRT, not used HRT. So in a way, we kind of owe to them because we've kind of picked from individual papers, thousands of research studies, putting them all together, looking at each
mm,
particular cancer type,
mm,
what was the outcome of HRT in those people who chose to take it after the cancer diagnosis and treatment, and what is the latest sort of recommendation from different societies and bodies. We've kind of pulled all that data together to create that table.
mm,
The importance being, I think, when we were trying to discuss what this book wants to give a message to its readers, especially those who are surviving cancer and experiencing menopause, the one question that comes to the mind is HRT for me, and how
mm,
risky it is? And there is no straightforward answer, as we know, because it depends on your type of cancer, your stage of cancer, your own medical history, what are your expectations. But as a sort of to go resource, one needs to come up with a sort of simple, easy to understand table, is what we
yeah,
thought, where you could look up the cancer you had and at least get an idea what the current thinking about HRT is in this particular cancer type. Are there any nuances? Are there any subcategories that I need to look at in that particular cancer? And what do most societies or learned bodies think about use of HRT in that situation? So that was really the idea for us. Give that initial information to the patient. Can you consider it? What do the current evidence bodies say? So that you can then use that information to have a conversation with your healthcare professional to say,
mm-hmm,
I feel there is a chance that I could consider HRT or I can consider HRT. Certainly, the references here or the papers here suggest that. Can we have a discussion? Or do you know
mm,
somebody who might be able to have that discussion with me? And can you refer me to that particular person, individual, or clinic? That is the aim of that table.
yeah. Halfway through of working on this, the British Gynecological Cancer Society, together with the British Menopause Society, published their own table. I believe it was done with a wonderful doctor, Christine Manley, a
Yes,
gynecologist from Bath and Bristol, who I've recently spoken to. Incredible. And so we've implemented their table and then added to it with all of the
correct,
other cancer
correct,
types. And
correct.
I thought it was quite timely because when I first entered this field, I always thought the controversy is only for breast cancer survivors. Those are the only ones that have an issue with either accessing HRT, or everyone is denied it, or most people can't even have a conversation. Did you have more studies come out in the gynecological sort of cancers? And is that why the British Gynecological Cancer Society published a new table? Were there more advances for gynae cancers?
Well, I think yes. I mean, every year you get certain number of papers, 10, 20, 30 good papers, which are looking at
Mm-hmm.
different cancer type, use of HRT in those particular subsets or subgroups of patients. The guideline, although was overdue, the guideline about
Yeah,
use of HRT following cancer should have come long, long, long ago. But it
yeah,
hadn't happened so far, which is why it was very difficult for somebody in a primary care or a general gynecologist to quickly go somewhere, look up the type of cancer and say, can I give you HRT or not? That wasn't available before. The good thing is the guideline with the Gynecological Cancer Society came around the end of last year. And I think what they did was they set up the body or a committee which looked at all the papers in the field, just like we did with our table, and they
yeah.
then summarized what's likely to be safe for prescribing HRT, what is likely to be doubtful, and what is likely to be definite contraindication. So they came up with those sort of all different diagnoses for ovary, cervix, then uterus, vagina, vulva. And then they said, these are fine, these are not fine. They used a red, amber, and a green sort of way of saying you can or you cannot give HRT. Now, I must say, we came up with our table before that, so we haven't taken it from them. And surprisingly, it matched well. So the recommendations from what the research we did for the book, as compared to the recommendations that came from guideline, were pretty much similar. We could easily amalgamate the two tables. So it's
Yeah.
good to know that many bodies or big bodies are thinking on the same terms as we do. Scientists are
Yeah.
thinking on the same terms as to most cancers, fine to have HRT, but there are
Yeah.
specific ones where you might have to consider carefully whether you are at high risk, and you might want to consider whether you want to take that little bit of risk considering HRT and your benefits outweigh or not. So that's where we are right now.
As a patient, when you see a yes, go for HRT after cancer, or when you see a no, contraindicated, these are the easier conversations to navigate. But on quite a few of our cancer types, it says speak to a doctor. So what I think we said is consult a specialist and
Correct.
talk about your own individual risks and benefits.
Correct.
Why do we have that there?
That's because we don't have either enough studies which can
Okay.
conclusively say this is safe or this is unsafe,
Yeah.
or there is no absolute right answer there. And every
Yeah.
individual's perception of risk would be different. I'll give you an
Yeah.
example of that. So let's say, for example, somebody has a particular type of cancer, and there have been very little studies about HRT following that particular type of cancer. And when the patient comes and says, okay, I'm all cured now, it's been 2 years since my cancer diagnosis, I've had my surgery, I've had my chemotherapy, I'm all clear, I feel good, all my imaging has been absolutely fine. But the one problem I have is terrible menopausal symptoms. You can then explain to the patient you've got different options: lifestyle, non hormonal, hormonal. And when it comes to the subject of HRT, the question will be, what is the risk that the HRT will bring the cancer back? And versus what are the benefits of that HRT in terms of quality of life, bones, heart, brain, metabolic, etc. It's not always possible to quantify this. And so you got to say, I can tell you that there were X studies following cancer using HRT in this group. And in those X studies, it looks like 5% or 10% or 15% women got a recurrence, which was not difference perhaps from the placebo group who are not taking HRT, or it was higher or it was lower. I'm just using an example here. But we cannot conclude because the studies are done in
Yeah.
few people with that cancer. So I can't tell
Yeah.
you in 1,000 or 10,000 women given HRT what would have been the numbers. And so you either say, I don't have any evidence, so I'm not going to be taking HRT. And if non HRT doesn't work, you're going to be suffering from the consequences of menopause and deal with it. Or we say, there is a little data, very small, we can't rely on it, but generally we feel that the little numbers don't indicate there is a risk. The numbers are same to the non-HRT group. There wasn't a signal that there was an obvious increased risk. The benefits are so many that actually, based on this small evidence, you will actually do better being on HRT rather than suffering the consequences. And one patient in this situation will opt for HRT, while another individual will say, no, I don't want the unknown risk. I will do all my best to avoid HRT. And so you never have the right one answer for the person. That's why those areas remain amber. It's between you and the patient weighing up what is bad, what is worse. That's when you come to that decision.
So you share uncertainty between the clinician and the patient. Is
Correct.
that how you?
Correct.
Okay.
It has to be. One has to be
Yeah.
honest to say, I don't know, I can't give you a number. I don't expect you to make one or other decision. I want you to evaluate everything in terms of the benefits, the uncertainties, possible risk, and then let's come to a decision. What might be right for you might not be right for the next person that walks through this door.
So if it's okay to hold and share uncertainty, who then holds the risk? Because the risk is what you're not certain about, right?
Correct.
So the risk is what we're holding together between the doctor and the patient. Who holds the risk? Do you feel as a doctor you hold the risk, or does your patient hold the risk?
I feel I hold the risk.
Do you?
To a large extent, I feel I hold the risk. Yes, of course, the patient makes the final decision and they will say, yes, I want to have this or not. But they're largely going by my presentation of facts to them. So the way I present facts could sway their opinion. If I
Yeah.
present an HRT favorable case, they're more likely to
Yeah.
say yes. If I present an HRT non-favorable case, an absolutely anti-HRT case, there's no surprise that no patient will opt for HRT. They
Yeah.
will carry on suffering and trying to take care of whatever symptoms they can on their own because they'll be worried I've painted a very anti-HRT case. And that's
Yeah.
what we see happening. That's what brings in the problems for patients is you go to one
Yeah.
clinician and they will paint a very anti-HRT picture. And
Yeah.
you will go to another clinician who might be very pro-HRT or favorable for HRT.
Yeah.
So so I feel the risk does lie with me if I'm going to counsel somebody about their use of HRT. And of course, the patient will then be the person who makes the decision. So they share that risk with me if they accept or not accept to take the HRT. So it's both in partnership.
There are many women who, despite the lack of robust data, entertain the thought of going on, for example, HRT after breast cancer, where we know it's a very contradicted area. People are almost arguing over it, and there is a very much a right or a wrong approach. However, patients do decide they want to perhaps hold that risk together with their clinician. And we get a lot of emails from women saying, I want to set up a network. I want to set up a registry. I want to collect data because I've now met 3 other people who are on HRT after breast cancer. And I am in my lifetime going to note all of that down to collect real world data. But I want to say to everyone, it's already happening out there. So where perhaps there is this uncertainty and you as a clinician and your patients are holding uncertainty together, that has become more uncomfortable to many clinicians and many
Correct.
medical societies, hasn't it? Because it's a difficult situation to be in. When I spoke to Professor Richard Simcock, for example, who is Macmillan's chief medical officer, he thinks the patient holds the risk and not the doctor. And so it's so interesting to hear how you all navigate this, because as hard as this is for a patient, it's probably as double hard for a doctor to have those conversations and to navigate those difficult talks with people. So what's happened out there? Talk to me about the registry from the Society of Endocrinology. I know you sit on the board. What was your involvement on it? Or you're part of it, or UCLH is registered as a site on it, is it? Or
Yes.
how does it work?
So Promise is basically promising to be the kind of go-to registry, a database for us in future, in 5 or 10 years, where we will be monitoring women who are on HRT for different reasons. One is cancer, but also other women taking HRT for other general indications, women with POI, premature ovarian insufficiency, or Turner's background. There will be women who take, say, GnRH medication to induce medical menopause. All of those women who will be offered HRT will be in future followed up for 5 or 10 years. So the program is meant to go until 2034, so 10 years since last year. And the good thing is it's real outcome data in real life. So these women will be having an app on their phone and they will be having different questionnaires and health information which they have to input year by year by year as they navigate their HRT journey. The good bits, the quality of life, the adverse reports, everything will be in that group of data that will be collected. Women will also be able to share their primary care information, so from their GPs, primary care practice, through that information database. So we have a bigger picture of their whole medical history. And so that will give us the missing gap information. What happens if somebody does choose to be on HRT in the amber group or in the red group? They make a
Yeah.
decision, they have HRT. What happened to them at 1 year, 2 year, 5 years, 10 years? How do we see that person's quality of life and other medical issues in comparison to the risk of recurrence that we were thinking that they would have? What was more common? Did they get the cancer back? Did they actually enjoy a good quality of life as compared to those who did not choose to go on HRT? What happened to their bones, their general medical health? All those questions, which we cannot answer now because there are no big studies, there are no real life outcomes following up patients for 5, 10 years, we will hope to capture them with these kind
Mm.
of registry studies. So that's why
Mm.
UCLH, we've kind of registered with the Promise study as a recruiting site, and
Yeah.
hopefully we're just in the process of setting up the logistics for the study now, and hopefully before the end of the year we will start recruiting for Promise.
Mm. Do you think you'll be oversubscribed or undersubscribed?
I think 100% oversubscribed. That's what I get from
Really?
my patients in the clinic. They're willing to share data, they're willing to share their experience, because every woman I know is really willing to give it out there, because what she
Yeah.
wants to do is another person should get the benefit of what I've gone through. You can see that
Huh.
across the
Yeah.
board. There's no person who will
Yeah.
say, I'm not going to be sharing this. Everyone is willing
Yeah.
to help. So hopefully, when we actually get cracking, we'll be registering loads and loads of women for the study.
Yeah. If you need more
I'm sure I'm
recruitees,
coming to you.
you can reach out. I
Definitely.
feel like these people in the amber group of your groundbreaking table, they have always been there. They have always existed, but they were never able to say because they were either embarrassed or ashamed, or they felt everyone would judge them or people would sort of shut them down. We meet them, they come to our workshops and talks, and they feel safe in our community. It's not that there are more now. I think they've always existed. They've always found doctors who holds the uncertainty and the risk with them. But now perhaps there is less embarrassment and shame about having made those
Yes.
decisions. So I understand that a registry like the Promise study will also help these patients, handhold the patients. What do you think that a registry like this is going to help you as a clinician with? Will
Massively
you
with
feel more
counseling.
safe? Yeah,
Yes,
yeah,
yes. Because as I
yeah,
said, look, depends on how I present the case for a treatment, whether it's HRT, non HRT, any other medication, depends on how your doctor presents it to you. You're likely to be swayed by that information. We are
yeah.
all human beings at the end of the day. We trust each other. And so,
Mm,
if I take an anti medication stand, you're less likely to go ahead with it. If I favor a medication, you're more likely to consider it as an option. And so, if I'm going to talk to somebody and tell them what HRT will do to them or what another medication will do to them, I need data. I have to be
mm,
honest. When I'm sharing uncertainties, I need to show the papers. Small numbers, small percentage, I can't give you a number. But if I have a promise registry for 10 years from now and I have the data, look, X number of women actually did consider HRT after this diagnosis. We followed them up for 10 years. These are the results. I'm very transparent, right in front, factual information,
mm,
no bias, no cherry picking, no presenting research which I'm liking or I'm disliking. Very honest conversation can be held based on transparent results. And then it's much
mm,
easier to arrive at that shared decision with the patient.
mm, mm, mm. If a patient now picks up our book, Navigating Menopause After Cancer, and looks at the table and thinks, actually, I've been told for many years I can't have local estrogen, for example. I've had breast cancer in the past. I've been told I can't have local estrogen. But here it says I can. So they go down the table, they find that type of cancer. They're not on any active cancer treatment. And so that advice might be conflicting to what they have heard for many years, perhaps as they've had conversations. I now can imagine that's a difficult conversation for our reader. What would you suggest the reader does with this information, should the information differ to what they've been told before?
Well, it's a difficult one, especially for somebody who has been given a particular advice and that maybe their own oncologist, their own gynecologist, their own GP. And often there is a difficulty in antagonizing people, which I fully
Yeah.
understand. It's very difficult to then navigate the healthcare system unless you have people on your own side. But I think if you read the book and you find, okay, this is my type of cancer, this is my situation, and the book does say that maybe I can have more treatments than I was offered before, whether it's HRT or others. Well, I think the next thing is to look at the references, look at some of the bibliography at the end of the book that relates to that particular chapter or a table. You can go online, you can search for similar information. There'll be lots of other bodies, lots of other studies which would have addressed the same issue to confirm what we're saying is right. And you'll see papers, you'll see references, you'll see studies which are corroborating the same evidence. And then once you've researched your little bit, take it to your GP, take it to your gynecologist, take it to your oncologist or your nurse who you trust, who's been working with you all this while, and say, I've just done a little bit of study on my current situation. I've read this book. I've done a few other studies online. I've looked at them. And they are all saying that there is a possibility X treatment may be offered to me now based on whatever studies that have come in the last few years. I don't think any health professional will take this bad. I think they will either signpoint you to another person who might be better at this or more expert at this, like a specialist clinic, or recognizing the studies you've brought, the book, they might say, okay, yes, we do agree with this. This got left out many years or months ago, but I think you can definitely have this option. And you might even get it straight away once you present the case. Yes, it's not going to be super comfortable, but I think it'll give you the strength to get to that point where you can have a conversation. You've got something to show that what you're thinking is right. And then the health professionals will hopefully signpost you if they can't help you themselves.
Yeah. It's very difficult for us as an organization we would never be able to say to people, do this or do that, because we are not healthcare professionals and we only just accumulate the information really from all of you amazing experts. But there was a workshop recently with a very big room full of breast cancer survivors, and a lady, she was over 12 years on from her active cancer treatment, on no more medication. She went to her smear test, and the smear test couldn't be performed because of severe vaginal atrophy. And her doctor said to her, well, that means you can never have a smear test again because you could never have vaginal estrogen. And it was very sad because she was very upset about not being able to have a smear test, which she felt was very important for her. And it, of course, is. And so what I have done in the book and in adding to Navigating Menopause After Cancer is I've made a digital handbook where I link the studies, because sometimes it's very difficult to go to the end of a book and try and type in the little numbers from all of you clever doctors into Google, and it never comes up with the right link. And I thought people aren't going to be able to do that. So I've made a digital handbook.
That's very useful.
And in around vaginal estrogen after breast cancer, for example, I just link to other menopause guidelines across the world. They differ a little bit. You talk about that so beautifully as well. And I've also linked to some larger studies. And I really hope that will help people to make it more practical, to get quicker to those references, to have those conversations, because I know it's not easy when you're being given conflicting advice or when someone says yes and someone says no. It's really hard to sit in that space in between. So
it is. And I think Dani, the important bit here is that it's not about having HRT. It's about making decision that I don't want to have it after knowing what it can do for me. So sometimes patients walk through the door, they may be able to have HRT. They're in that amber group where it's not contraindicated completely. They're suffering. And then they come and have a discussion with you. They discuss non-HRT, HRT options. And at the end of it, many of them will say, I will now consider HRT. I know what my benefits are. Yes, there is a bit of uncertainty, but the risks appear small. And for me, that trade-off works, and they choose HRT. But equally satisfied are those people who then say, I've understood the whole case. I wasn't clear about this. I still choose not to take HRT. But I now know why I choose not to take HRT. I now will concentrate more on all the non-HRT lifestyle option and not regret that somebody didn't discuss it with me, somebody did not give it to me, or I missed the opportunity. Because I know all the facts and I have made this decision. That itself can be empowering. So it's about telling that person what all options they have, what are the pros and cons of each, and let them decide what is right for them. That doesn't happen consistently. We need to
Yeah.
let that happen for every person who is at menopause after cancer.
Yeah. So do you feel with the PROMISE study, we're heading into the right direction to give clinicians more support, to feel that patients are being part of a registry, to give us more knowledge in 10 years to come? And in the meantime, going back to the very beginning of our conversation, we need to educate more healthcare professionals
Yes,
to have those conversations, right?
absolutely. I mean, PROMISE is one of the tools in the armamentarium. It's one of the very good tools we will have, but we'll have to wait for data to come through another 5 or 10 years. It's going to be a
Yeah.
long haul. In the meantime, though, we have plenty of information already, which we can
Yeah.
utilize effectively to signpost people. That's not happening, but hopefully, as more people sign up to train, more people get interested in menopause, charities like yours are working day in and day out flat, we will make little by little progress. So most people get the right information well in time.
I can't thank you enough for all of the work you've put into that table and into supporting us throughout the last many years. Honestly, it's been
Pleasure, Dani.
absolutely amazing. I don't think we could do what we do without your guidance continuously throughout everything. Vikram, my last question to you is, what do you hope is going to happen in the gynecological sort of area, so away from the breast cancer, because I know you speak to so many people in that field, and for education in the next 10 years? What do you hope we can give to other healthcare professionals that are listening to this?
It's plenty. There is plenty. Future is bright. I think we've just made a start. Yes, you say the revolution is at the peak. I would disagree with that. I think there's plenty of long way to go in terms
Really?
of,
Yeah.
especially in menopause and cancer. Maybe revolution in general menopause. Yes, agreed. But with menopause and cancer, I think this is the
Yeah.
start,
Yeah.
and we should build up on this momentum, and more so for people in UK, US, in developed or high resource countries. I think we are doing good now. We are trying to get attention, and women are getting the care. My heart goes out to people outside the rest of the world, where there are hundreds of hysterectomies, hundreds of oophorectomies, hundreds of cancer treatments are done with no mention of menopause at the end of the day. And
Yeah.
so really, I think what we've started here, the next step will be to build up to make this conversation go global, for
Yeah.
people outside of the high resource countries to get that information about menopause, their long-term health, well in time when they're expecting cancer treatments. And the other bit is less fighting between health professionals. I think
Yeah.
it's time now is that for people to sit together rather than antagonizing, rather than conflicting each other on media, for example, to try and sit down and work in the best interests of patient. Because when health professionals don't agree, fight, or have conflict, and often give antagonizing approaches to patients, it's really difficult for that person to navigate any area of healthcare setting. So the two things I'm looking for in future: one, the education training continues in UK.
Yeah.
People don't fight. People sit down together, come up with best interest patient in mind, and for all this to go global in all the rest of the world, so that women can benefit.
Small plan, little project, done and dusted. Thank you. Thank you so much for today and for
Pleasure.
everything you've done throughout.
Pleasure, Dani. Thank you.
Thank you so much for joining this very special episode, the first one since the launch of my book, Navigating Menopause After Cancer. Absolutely huge thanks to Mr Vikram Talaulikar for sharing his time, insight, and compassion once again, and his really valuable contribution to the book itself. Their response to his work, especially the HRT table, has already been overwhelming, and I know this conversation will help so many more. If today's episode resonated with you, please consider sharing it with someone who might need to hear it. And of course, you can get a copy of the book Navigating Menopause After Cancer, and just head to Amazon. I'm going to put the link in the show notes. It is filled with so much expertise, with all of your non-hormonal options, with all of your complementary therapies. We talk about collagen, vitamins. I have not left anything out. And I've also added loads of real stories from survivors, of course. It's the kind of practical support I wish I have had years ago when I was thrust into surgical menopause. And if you're a healthcare professional listening in, I really do hope that this resource will be a really good guide and handbook for you too. So until next time, please remember you're not alone. There is always something you can do. And thank you for being here and having these sometimes difficult conversations with us. With all my love, Dani.